I think we can
Good
start.
morning. Yeah, we'll start. Yeah.
Okay.
Good
Yeah.
morning to everyone. Today, Dr. Norman is presenting our CME on fever, facts, and myths. Fever
Okay.
is one symptom that ticks off all parents and is one of the most common reason why um,
Perfect.
children are brought to the clinic. And this is one symptom where no matter how much of education you give, parents come back again and again asking the same questions. Very few of them understand that fever is a protective mechanism. Usually, it's a protective mechanism, the body warming up to fight an infection. But although there are other causes of fevers, the most common cause is infection. And we'll see the facts and myths that Dr. Norman will present. Over to you, Dr. Norman.
Okay. Good morning, everyone. I'll be talking about fever, some facts and myths. So, how do we define fever? It's an elevation of the body temperature above normal due to a hypothalamic regulation, which has varying thresholds. Pyrexia would be the more formal medical or scientific term that we use. Now, as for the definition of fever, these are the different organizations that define fever, have defined fever, and most of them will define all of them will define fever as around more than 38 degrees Celsius. Now, why 38 degrees Celsius? It is to, well, first it's for standardization, and that we don't overtreat anything like less than 38, which might be still part of the uh, normal threshold. Okay, so temporal relation. So fever, fever early morning, it's 36 degrees, higher around late afternoon and evening. So for infants, the infants and younger children, there might be wider fluctuations, and they're more prone to rapid rises. So activity and environment also uh, affects our temperature. So a quick one. So the ancient and classical understanding of fever as early as 5th century BCE, fever was considered a natural healing response. We um, regressed a bit in the Middle Ages when the fever was considered a divine punishment. And then, uh, hello? Oh, okay. So in the 19th century, I want you to take note in 1968 how we actually got uh, 37.8 initially as the threshold as when we consider one having fever. Karl Wunderlich in 1868 measured the temperature in 25,000 patients by the axillary method, and he documented this one, so fever became a quantifiable, measurable sign. So in the 20th century, we discovered pyrogens, endogenous and exogenous, and we understand now that the fever is part of an immune response. So in the modern era, we saw the role of cytokines and the regulated process that involves the hypothalamus. Now, clinical guidelines also made us distinguish between febrile illnesses, hyperpyrexia, FEOs. Okay, so before the onset of antibiotics, fever was actually used for therapy in neurosyphilis, tuberculosis. So they tried to find a way to increase the temperature to combat these infections. So now there's some considering it for cancer treatment and still some modern experimental uses for resistant infections. These are experimental and not included in clinical practice. Now, Also, we need to know about hyperpyrexia and hyperthermia. Hyperthermia, hyperpyrexia, sorry, is extremely high fever, around 41.5 degrees. Some clinicians use a slightly lower threshold at 41 degrees. Still, the brain's hypothalamus raises the body's set point temperature in response to underlying illness. But having hyperpyrexia, we should try and uh, lower the temperature at once. This one would still be uh, can still be decreased by using antipyretics. Hyperthermia, though, is an abnormal elevation of the body temperature that occurs without a change in the thermoregulatory set in the hypothalamus. So, your antipyretics won't work here. So usually this one you would want to use cooling methods, sponging. Now, the pathophysiology of fever. So remember that the preoptic area of the anterior hypothalamus, that's where the hypothalamic set point is. Okay. So in an immune response, your cytokines stimulate phospholipase A2 in the preoptic region of the hypothalamus, which in turn produces the prostaglandins, which raises the hypothalamic set point. Now, what are the benefits of fever? So, these are the following: it inhibits pathogen growth, enhances immune function, it triggers an acute phase response. Now, this one, it also, as far as nutritional immunity is concerned, it decreases iron and zinc. It tries to sequester it away from the pathogen so they don't have enough nutrients for replication. It increases the copper because copper is toxic to microbes. So in effect, it starves the pathogens of the nutrients. Now, the protective physiological changes, somnolence, anorexia, behavioral changes, it conserves energy for immune defense. Anorexia, loss of appetite, it reduces your iron intake, and behavioral changes, seeking warmth and rest. So the evidence of the protective role of fever. So now they find that fever occurs simultaneously with lymphocyte activation, showing it's part of the immune strategy. But take note, the optimal immune processes are around 39.5 degrees, where host defenses are most effective. Now, how do we measure fever? So these are the methods: oral, rectal, axillary, tympanic, temporal arch, and esophageal bladder. Let's get the bottom one out of the way. This is used in the hospital, but the accuracy is quite high. Rectal measurement is considered one of the most accurate, but it's invasive and uncomfortable. It's used for infants and ones for critical care. So the AAP actually recommends this for those less than 2 years old. Nice guidelines does not recommend it in less than 5 years old.
Dr.
Uh,
Norman, just want to interrupt you here. Can you make your screen full screen because
Full screen. Wait, let's
it's
see.
not visible
This one. Oh, wait.
on the right top corner?
Uh,
The icon
wait.
next to the X, to the left of X. Just click on that. That should make you full screen.
There. Does that work? I can see mine. It's big now, but I'm not sure with your side. Can you see?
It's still not full screen.
Yeah, but did it become? It did not become big.
Um,
Wonder why. Wait, give me a second.
Maybe
It's,
you should just Yeah, from current slide. Start the slideshow. Click on that, and
Start the
maybe it should.
slideshow. Okay, give me a second.
Sorry to interrupt, because otherwise it might affect visibility.
From beginning. No?
No, it's fine. I think
Still the same?
still the same.
Yeah, because in my part, I can see it's
Yeah,
bigger.
maybe because your slideshow thing is 80%. Make it full. Draw that. Maybe that's just your volume button. That's okay. I think we'll go ahead. I don't want to interrupt your presentation for too long. I thought maybe it's a quick fix, but doesn't seem to.
Okay.
That's fine. Please continue, Dr. Norman. Sorry, the interruption.
Uh, okay. So we actually use more the team in the OPD. We use the uh, uh, tympanic method. So we measure the core temperature to the ear. Because it says that it's actually similar to the blood supply of the hypothalamus, so it might be closer to the actual core temperature. Okay, so as far as the fever severity goes, we have mild, moderate, high, and hyperpyrexia. So as far as mild, it's 37.5 to 38.5, moderate 38.6 to 40 degrees. So as far as the benefits of the fever, up to 40 degrees, there's stronger immune stimulation, enhances T cell activity, and conserves energy, like we mentioned before. While 40.1 to 41.5, while still immune supportive, it says the benefit might be diminishing. For hyperpyrexia, there's no added immune benefit and might be dangerous actually. Okay, so I just wanted to remind you regarding special populations as far as fever interventions are concerned. So anyone less than 3 months. Oh, sorry. This blunted fever response is for elderly adults. Okay, pregnant women, immunocompromised patients, and neurologic patients. So how do we manage? Sorry, fever. So we give antipyretics. This is the list of antipyretics that has been used. I was old enough to see in Nelson before that initially the first drug of choice for fever was actually acetylsalicylic acid. The next edition, that one became paracetamol. So, okay. And these are the methods by which we give it: oral, rectal, intravenous, intramuscular. There are some experimental methods via transdermal and subcutaneous route, still experimental, then that standard practice. Now, I think we all agree in our center, these are the ones that we use: paracetamol, ibuprofen, and diclofenac. Oh, sorry. Okay, from this one, yeah, it's a bit loaded, but what I want you to just see is for paracetamol, it is the most common antipyretic to be used. The bioavailability is 70 to 90%, with peak plasma concentration reaching in 30 to 16 minutes. So the unique mechanism of action of paracetamol is the has peripheral cost inhibition, so no significant anti-inflammatory effect compared to NSAIDs. Now, the dose maximum is 4 grams per day to avoid hepatotoxicity. The children, the maximum dose, well, for now, the maximum daily dose, it says here, is 60 milligram per kilogram, and it's 10 to 15 milligram per kilogram every 4 to 6 hours, but we'll get back to that later. Okay, so as far as how it is given, it's oral, rectal, intravenous. I'm not sure if I've experienced having giving intramuscular uh, paracetamol injection in the Philippines, but I haven't seen it here. And then uh, oral paracetamol, 30 to 60 minutes. You can see rectal has variable bioavailability because it will depend on how you insert it. It will depend on the veins inside the rectum as well. For intravenous and intramuscular, the bioavailability is 100%, and then intramuscular is 90 to 100%. Okay. So this is important because most of our patients will think that rectal giving rectal suppositories, paracetamol rectal suppositories would be quicker as far as the onset of action and the decrease in temperature is concerned. So for me, I just tell them no, it's actually not, but it's just easier for some. Okay, so again, uh, the mechanism, just as a reminder, the mechanism of toxicity of paracetamol, which I think in itself is already a topic. It's normally metabolized in the liver via glucuronidation and sulfation, but a small fraction is metabolized by the cytochrome P40 to NAPK. It's a highly toxic metabolite, and it is detoxified by glutathione. The toxicity comes when your glutathione stores are depleted. Okay. Now, so the toxic dose here is 150 milligram per kilogram per dose in children. So if you have 10 kilo child, that means you would, before you can have the toxic dose, you will have to be giving 1,500 milligrams of paracetamol, which I think is more than uh, 10 teaspoons of paracetamol. So the clinical course, so early we'll have nausea and vomiting, liver enzyme elevation later, and hepatic failure after 3 or 4 days. So the management is activated charcoal and N-acetylcysteine. However, paracetamol is safe and effective at recommended doses, but the overdose leads to life-threatening napkin accumulation. Now, another one that we use is ibuprofen. It came about during the 1980s as something that we treat arthritis for, but during the 1990s, they found that it's a good alternative to paracetamol. So it's a non-selective COX inhibitor, so it blocks both COX-1 and COX-2. The bioavailability is 80 to 100 to 100%. It is a minimal first pass metabolism. They found, however, that ibuprofen actually is better absorbed if there is no food. Now, those, oh, sorry, second. Okay, so the weight-based dosing is critical. So 5 to 10 milligram per kilogram every 6 to 8 hours with a maximum dose of 40 milligram per kilogram per day. So What I've noticed though, the 5 milligram per kilogram every 6 to 8 hours, if I look at the insert in Brufen, so that's how they give the dosing. But in the US, I think when they use Advil, they use 10 milligram per kilogram. Both are still okay though. As you can see, I've included a picture of Nurofen suppositories. They do exist. Some expats, when I see them in SAR, they actually have this. And then also as a reminder, some expats also bring those double strength ibuprofen. So sometimes I need to ask them where they bought their Brufen because there were a couple of patients who actually had a double strength Brufen, and I might mistakenly give them the wrong dose. Okay, so this one is just a study regarding suppositories as far as paracetamol and ibuprofen is concerned. So Brufen actually works as uh, rectally, okay, in studies. Now, as to the issue of diclofenac, diclofenac is absorbed orally, but the bioavailability is only 50 to 60 percent. Okay. As far as studies goes, and when you talk about reducing the fever, diclofenac does work. Okay, but again, they don't recommend this because of the side effects. Okay. Now, what is the actual dose? This one actually is based from the Okay. This one is based from how it is given for pain and analgesia. So it's 1 to 2 milligram per kilogram per day, not to exceed 3 milligram per kilogram per day every 8 to 12 hours. The bioavailability is actually much better when you give it rectally because there's going to be minimal hepatic first pass. Yeah. Okay. This is a study I found about the guidelines in the symptomatic fever management in children. Okay. What they did was they reviewed all the guidelines that they found globally. So they found 74 guidelines from 55 countries. Okay, and these are the some of the countries. So I think it's more or less well represented. The conclusion is that some of the recommendations are supported by high level of evidence, but there are some that have striking discrepancies in the low level of evidence supporting most of the recommendations. However, these are the ones that they found out as far as guidelines are concerned. Parents and carers should be educated about fever. Okay, and then for children with acute febrile infection, treatment should focus on the reduction of distress rather than temperature. Antipyretics should not be combined or routinely alternated and be used if at all as only as long as the child appears distressed. Antipyretics should not be given with the intention of preventing febrile seizures, and they discourage external cooling. Okay. These are just a summary of the recommendations. Okay, and no, sorry, don't. This is just a table for those guidelines. I don't think you can see it, but just let me point it out to you. There was no threshold for treating fever, like at what temperature should we start to treat? So there was no consensus among this. There is no evidence. Most of the guidelines would say no, there's no threshold. Just treat the distress. but there were 22 guidelines who said 39. Let's treat them at 39.5, although there was no evidence to support it. So as far as paracetamol is concerned, most of the guidelines accept it as the first line and it is safe. Okay. Now, as far as how the dose is given, so here it says here 10 to 15 milligram per kilogram. That's level one as far as the recommendations are concerned. Level five means expert opinion. So at 20 milligram per kilogram per dose, there's level 3 against it because there are reports of it showing harm at this dose. Okay. Now, how do we give it? Do we give it every 4 hours? Do we give it every 6 hours? There's no actual published evidence for every 4 hours or every 4 to 6 hours, but there's a level 5 evidence for giving it every 6 hours. As far as the maximum doses per day, uh, guidelines report 4 doses per day. Okay, that's again, that's level 5. So- Okay, so as far as the maximum dosage for 24 hours, 9 guidelines mention 60 milligram per kilo per day. There are some guidelines that says 75 milligram per kilo per day. Some guidelines went for as far as 90 milligram per kilogram per day. As far as the duration of treatment, level 3 just for 72 hours. Okay. Now, this one is for ibuprofen use. Most there's no, okay. So 53 guidelines recommended for temperature reduction. A lot of diseases says to avoid it. So if you have Kawasaki, influenza, chicken pox, okay, there are level 3, level 4 recommendations for this. And then, okay. Now, other antipyretics, okay, I just highlighted diclofenac here. There is one study that recommended it as second line, and then how to give it every 12 hours, but there's no published evidence as far as how often we give it. As far as alternating, okay, it's not, most guidelines do not recommend it. 8 guidelines alternate it. And for the prevention of febrile seizures, there are actually 10 guidelines that recommend it for preventions. Okay. Now, this one I just wanted to highlight some of the physical methods that are actually being used by some of the guidelines. Some of the guidelines recommended lukewarm baths. Uh, 33 actually recommended tepid sponging. Okay, and then alcohol rubs, 12 did not uh, recommend it. Okay, and the reason I show this is because patients sometimes ask these compresses, sponging, okay, and then so ambient temperatures, how the child is dressed, cover, uncover, do we let the child dress even if he wants to play? So those are the things include as some of the guidelines included. Okay. Now, I was trying to find something for fever phobia, and I found this. I cannot really find the article; I just found its conclusion, but it went far back as February 1980. That we should educate people to counteract fever phobia, and it should be part of the routine pediatric care. Now, this one is the paper about the analysis of nurses and physicians' attitude towards fever in children. So, uh, in this study, some physicians still see fever as harmful and may cause the brain damage or seizures. Nurses share the same similar fears. Okay. Physicians give a treatment threshold at 38 to 38.5 and sometimes lower. And nurses are the same way, so the parents also act the same way. So as far as the focus of care is concerned, we physicians still emphasize child's comfort and overall appearance, but still overtreatment exists. Nurses are influenced by parental anxiety and peer practices. Parents, however, focus on lowering the temperature quickly, equating fever reduction with recovery. Okay, so physical methods, physicians, nurses, and parents, we sometimes still use sponging. Knowledge gaps, misconceptions still persist among among three physicians, nurses, and parents. Guidelines are slowly shifting practice, but still parental pressure is there. Okay, so as far as parents are concerned, the influenced by fear, cultural tradition, and even advice from healthcare providers. So what about educational impact of these guidelines? So physicians still we do know the guidelines, but we don't really fully change uh, practice. Same with the nurses, educational programs improve knowledge, but the perceptions are hard to shift. So educations from us sometimes reduce anxiety, but misconceptions are still widespread. Okay. So in that review, most authors seem to agree that the aggressive fever management by professionals promotes parental fear of design and their desire to achieve normothermia in their children. Okay, so how did they try to approach educating physicians and parents? So randomized controlled trial, effect of video-based distance education for approaching children, fever for education for caregivers in the emergency room. So this one, they started this one in the last one, childhood fever in medical students. So as far as medical school is concerned, they are already trying to train the students about fever phobia. Okay, sorry. What does up to date say? Okay, up to date. Oh, okay, just look at the last part says mostly what we've been saying about this session. Fever is not an illness but a physiologic response. Temperature thresholds that define fever vary with age. There is no evidence that fever makes the illness worse. Most fevers in children are benign, and we should provide re- fluids and see if we can reduce activity. Okay. Here, I've highlighted children who are receiving treatment for fever do not need to be awakened to receive antipyretic agents. And children who are receiving antipyretic medication should not be given combination cough and cold uh, preparations. Okay, so these are the questions that I want to address to you. So, what strategies can we use to educate primary givers? When I say primary caregivers, that includes not just us but parents as well. Can we make our own guideline, and how do we implement it? So, with that, if you have any questions. Okay.
Thank you, Dr. Norman. Are there any questions for him? In fact, I should mention here that Dr. Farah and Dr. Mariam from KJMH, they came up with this educational flyer for parents, or educating them about fever. I would expect that I think other units also have this by now. If not, I think we should keep this available for all the units of arms, especially the pediatric section.
Yes, Doc. The thing is, in some of those studies that they did, they also tried to assess how the educational materials impacted the doctors and the community. So, are we going to do something like that as well? Like, like
Study.
how they found it,
Um,
or are we just going to like uh, uh, give the flyers and just see patients' response to that?
Dr. Farah is here on the meeting. If you're able to unmute and speak, Dr. Farah.
Hello, can
Hi,
you hear
doctor.
me?
Yeah.
Hi, thank you for the presentation, Dr. Norman. Just I need to add a few points, if that's okay.
Yeah.
It is, I mean, as we all know, fever is nothing, it's not a thing to be worried about, it's the actual illness. So I think we should emphasize that we are treating the illness, not the fever itself. In an immunocompetent child or a normal child with no immunity issues, not any other treatments, the height of the temperature should not be is not an indication for this child having bacterial illness. This also means that if the child comes with fever 40 or 39, this should not make us panic. If the child is immunocompetent, otherwise well child, the thing that we need to focus on, it's not the temperature, but the other vital signs. We have to make sure that the vital signs are normal. The child appears okay, well enough. He's not in shock. These are the things to look for, not the temperature itself. So we don't base our investigations on the fever itself, but on the other markers that indicate if the child has sepsis or not. Because most of the children that we see are not septic, they just have viral illness. The studies, I mean, have shown that most people who come to the emergency department or to the clinic, if they don't have any background illness, they will be having a viral infection. The other thing is to recommend that also the response to antipyretics is not an indication of bacterial or severe illness. So if the child is not responding to antipyretics and but he is otherwise well, that is also not a cause for alarm for the physician. Studies have proven that this does not also indicate bacterial illness or a severe illness. So these things. I will make sure the leaflets get distributed to the other departments. They are They are like traffic light system for the parents. They tell them when they need to see the emergency, when they need to see their GP, and when they need to call the ambulance. So just a few indications. And
Uh,
none of these is based on the height of the temperature or the response.
Bisa nggak Sebentar.
Can I request others to mute themselves? Yeah, go ahead, Dr. Farah.
Yeah, so basically these are the points I wanted to add. If anyone else has a comment, they're welcome.
Yeah, another thing is the causes of fever. Of course, the most common cause of fever in pediatrics is infection. And of the infections, almost 80% of them are viral infections. So I think history taking will be very important in dealing with fever rather than just the height of temperature. If the child is otherwise well between fever spikes, is activity and the appetite is almost near normal, I think we as physicians should reassure patients and then have a safety net where we ask them to come back for a follow-up if any of the red flag symptoms develop and child has worsening symptoms, rather than because I think in the studies that were shown, that Dr. Norman showed, physician misconceptions are one of the reasons why fever phobia tends to persist. So our approach to fever and how we deal with it is paramount to reducing the parents' fever phobia. So that becomes important.
Doctor, the thing also is, I did notice that we have different, you mean, approaches to how we manage the fever. I'm just wondering if we can like harmonize, like how we
Standardized.
do it. So,
I
like,
think what
do
we
we
can
give?
do is run a a Google sheet with questions and run it across cross section of either pediatricians or amongst the whole the whole hospital, and then find based on the responses, categorize as to how each one deals with it, and then come up with some standardized approach. But that's a good thing.
Yeah, that would be good. So at least first amongst pediatricians first, doctor, right? Rather than the whole hospital.
Mm. No, why I said whole hospital is very often I find it must be your observation as well. We are having families being affected with viral infections. Very often we find that parents are started off on antibiotics. When here we're diagnosing a child with influenza A, parent comes from the emergency with a prescription of an antibiotic. So there seems to be the approach to fever and its treatment certainly
Oh.
needs a look. So do you want to create this Google questionnaire on a Google?
Yeah, maybe we can do that. I mean, like for
Initiative.
example,
A couple of us can also put in our feedback, and then once it's finalized, we can pass it around and get a feedback.
see if we can like at least uniform, well, more or less uniform management as far as fever is concerned.
Well, clearly, based on your presentation, alternating and antipyretics is not recommended. But I see that is one of the common practices that we still follow.
Yeah.
This is only to safeguard parentophobia, about parents' fever phobia.
I will be honest. Sometimes I do like feel that pressure at times, and also and sometimes also some parents actually know. They said they know that fever is like this, that it's actually an immune response, but still they come to the clinic. They're going to be they're still afraid. That's the thing. But they do know that they're educated about it, but they're still afraid. So sometimes they just go to the clinic to feel safe.
Any other comments or questions before we close? Yeah, thank you so very much, Dr. Norman, for
Okay,
picking up
thank you,
this
doctor.
common topic that is riddled with still a lot of challenges. Hopefully, with the suggestion of yours and the Google responses, we'll hope to standardize our approach to treatment of fever.
Okay, doctor. Thank
Yeah.
you and
Thank
good
you very
morning.
much. Thank you all for joining in short notice. Have a great day. Bye.
Okay.